Hello, it's a little bit late and I'm sorry about that, but I am here and I made it home and I am doing this Facebook Live question and answer. We got quite a lot of questions tonight, which is absolutely fantastic because it was half term last week. So we've had a rollover week. So it's a rollover and it is every Tuesday at 7 p.m. ish. We do this, and the other thing I'm going to say is please comment and share. Please feel free to comment and share. I am hear me now. Right, we're going to do some questions right here, which I've got preordained. But if you've got any questions, then please ask away. We've got a question here which says, are there ways to improve breast fullness without plastic surgery? Will going to the gym, chest exercises help? No. Gym is good and will help to tone your body, to improve your shape, get definition of your muscles, and it will be good for your body. But specifically, you're asking about breast fullness. It will not do anything to give you more breast tissue. And breast is made up of fat and breast tissue to a variable degree. Some people have more fatty breasts, some people have more glandular breasts. You can't really tell by looking at them. So in fact, if you were to lose a lot of your body fat, you would actually lose fat from your breast, so actually get less full of anything. Don't want to put you off going to the gym, but if you have a look at bodybuilders and things, they've often got, just bodybuilders, they've often not got much in the way of breast volume because all the fat is gone of their bodies. They have just pure muscle. So I don't want to put you off going to the gym. Going to the gym is good, but it's not going to improve breast fullness. Let's just say it's not going to improve breast fullness. It's going to be good to make you healthy, and it's good for your health and your life, and maybe make your body more toned, but it's not going to make you have more breast fullness. So are there any ways to improve breast fullness without plastic surgery? Not really. I mean, obviously pregnancy, not terminal. God, what's the word? Transient. Not transient. Anyway, temporary. I think the word was. Whatever the word was. Crazy thing, but you know, there are physiological things that happens like pregnancy. But yeah, no, stupid thing to say. We haven't said that. No, there's no way to make breast fullness without plastic surgery, really. He would say that he's a plastic surgeon. He would say that he's looking for business, isn't he? It isn't. I'm not just saying that. And you know, it's true. Zoe, good to see you tonight. Good evening, Steph. Looking lovely. Am I looking good? Looking good. Thank you. Changed my blade for my razor yesterday. Oh God, still a bit. I changed the blade yesterday, so that was a big day for me. Easily pleased. So good to see you all. We've got a question here, which is from. Do I look like I got a pointy head? A little bit of hair there. Khan. That's a good name. Good to see you, Khan Olia. How long should I wear the binder stroke garment for after a tummy tuck? I don't see who these questions are from. So I don't see them, period. But also, even if I did know who they were from, I wouldn't say, because it's all confidential as far as I'm concerned. So if you do ask a question, it will be treated in a confidential nature. And I won't say, oh, this question's from, you know, so-and-so who lives at, so, you know, I'm not going to say your name or anything like that. So, but similarly, I don't even know. So what a point being, I don't know if this is from my patient or not, asking about the tummy tuck, because the first thing to say is, how long should you wear a tummy tuck? How long should you wear a binder after a tummy tuck? The answer to that is it depends on. Oh dear, sorry, I got my head off. It depends on your surgeon. So ask your surgeon is the answer to that. If you're my patient, I think I should have given you a post-op instruction sheet. So I hope I would have covered that with you. But if I haven't, I say day and night for a month is what I say. Obviously, take it off to wash. The swelling starts to subside around 3 months, but it's quite a lot to say to someone you've got to wear a binder for 3 months. So I normally say a month. After a month, you can continue to wear it. And sometimes you'll say, oh, I feel a bit more supported with it. I quite like wearing it. That's fine. Sometimes, especially in the summer, it's really hot, people say, for goodness sake, let me get rid of this, and say, okay, that's fine, you can get rid of it after a month. But and you might just want to wear it when you go out to crowded places if you feel a bit more protected, sort of thing. But yeah, I say day and night for a month and then see how you go. The swelling won't have completely subsided by then, but you know, that would have helped. So it's for your comfort, really. Hi, Brenda. Nice to see you. This is friendly, isn't it? This is friendly. Junie, hello. Nice friend. It's like a little sort of soiree. It's not. Yeah, maybe it is normally that. Yeah. Been off for the last 2 weeks. Forgotten. It's good. Thank you. Thank you all. Can I speak with someone? Can I speak with some of your past breast implant patients for advice? Yes, you can. And I think that's important to speak to people who have had it done, real people who've had it done, because we can give you an idea about what you can expect in terms of pain and swelling and shape and form and going to work and driving and all that sort of stuff. But I think it is always good to talk to a real person who's had it done, because I think they will often have a different input on it and a different angle on it. Although, you know, there's a swings around. I mean, we see a lot of people, so we can give you an overview of a lot of people. When you speak to one person, you're getting one person's, you know, experience. So it may not be that easy to translate to how it would be for you, but I think a lot of people like speaking to patients. For that reason, we always say that we will put you in touch with a patient. We've got our buddy scheme, which means that if you come to the clinic, we'll put you in touch with someone who's had it done. We've also got a closed Facebook group, and that Facebook group is just for patients of the clinic. So if you've been to the clinic, you will have been invited to the Facebook group where you can talk to other patients, either openly or direct messaging each other. So yeah, I think it is good to speak to previous patients, and we do encourage that, and we will facilitate that by putting you in touch with someone who's had it done. Hopefully someone similar to you, or who's having obviously a similar procedure to you. Obviously that would be quite important, wouldn't it? But certainly breast implant patients, we've got loads of them. So yeah, be very happy to put you in touch with someone who's had it done. Yeah, that's something we are quite keen on, and something I've been quite not anxious, but keen to facilitate. Just probably the wrong word. I'm not very good at my words tonight. Will a caesarean section or hysterectomy after tummy tuck results? Okay. Perhaps I should have proofread these questions before I just go ahead and just read them. Will a caesarean section or hysterectomy affect... Oh, hold on. No, that's okay. That does make sense. That does make sense. Will a caesarean section or hysterectomy affect tummy tuck results? Okay, that's how it should be read. Okay, so that's proper reading of that question. Will a caesarean section or hysterectomy affect tummy tuck results? Yes, that makes sense. So the... Lord, what? Anyway, no. Keep it pro. I'm keeping it pro. Focus on the focus. I'm looking at the screen, and I'm going to answer that question. Will a caesarean section or hysterectomy affect tummy tuck results? No, it won't. The only thing I would say is, first of all, hysterectomy, absolutely fine. Caesarean section, the only thing I think, if you're asking that question, obviously there's a pregnancy involved when you talk about caesarean sections. So a pregnancy will affect a tummy tuck result in that the skin will be stretched. If you have a pregnancy after a tummy tuck, it's fine to be pregnant after a tummy tuck. There's no problem with that. But it will potentially stretch the skin again, because a lot of people need a tummy tuck because they've had a pregnancy or because they've lost weight, because the skin's been stretched by something. And so that might stretch the skin. So that's the first thing. The other thing is, obviously, if you're having a caesarean section or a hysterectomy, you may well be having that scar. They don't always do the scar for hysterectomy, but if they do the scar, then that will affect the scar, because they'll suture the scar. We spend a lot of time suturing the scar and making sure the scar is nice. So potentially, maybe the scar would not be as nice, perhaps, but they might suture it. I mean, a lot of caesarean section scars a few years later look perfect. So yeah. So actually just reopening that scar, and I would advise them to reopen that or excise that scar and give you a new scar in the same place rather than giving you a second scar. Sometimes I see people who do surgery in the same area giving you multiple scars. I would advise, well, I'm talking to patients here rather than surgeons, but you know, so you maybe not want to have too much an opinion on that. But if you have got a scar there already and having another operation using the same scar, I'd say, look, cut that scar out and give you just replace it with your fresh one rather than giving you two. But anyway, that's that question there. Smidge, good to see you here tonight. Smidge, you have contacted me on Facebook and asked for an opinion, and I am just opening my email because you couldn't give me a photo. I'm happy to give you my opinion here if I can get your photo, or I'll just do it privately by email. Let me know. So where are we up to? I have a hernia. That's where we're up to. I have a hernia. Because I'm multi-computering here. That's how big time I am here. Oh man alive. So there we go. Not seeing a photo from you, Smidge, but I'm keeping out for it. I'm looking out for it. Look at that. I've been nominated for the Game Changers Award 2019. Been nominated. Finance Monthly's Game Changers Award celebrates the success, innovation, and strategic vision of professionals across a number of sectors, industries, and countries, identifying the most successful, innovative, and forward-thinking game changers in business today. You're hearing it live, people. This is an email just come in. Huh? Warmest congratulations on your nomination and kindly ask you for immediate assistance. Got to have further. They want further supporting evidence to accompany my nomination. Who nominated me? That's great. Okay. Brilliant. Well, listen, I've been nominated for a game changer. Game changer. Yeah. Right. Anyway, digressing there. Stop that digression right now, young man. And we'll go back to this. I have a hernia. Thank you. Thank you. Looking at a game changer here, my friends. Okay, 2019 game changer right here, nominee. So I have a hernia. Can an abdominoplasty be done at the same time as the hernia repair? Yes. Does that question come up? Yeah. Is the repair bit not quite come on the screen probably? Anyway, that is absolutely fine, and that is normal, I would say, depending on the hernia. It's very common to have a degree of a hernia when you are doing an abdominoplasty. Sometimes you find it incidentally. Sometimes people know they've got it there already. And it is usually fine just to go ahead and repair it. Sometimes people have the diversification of the rectus muscles, where the rectus muscles, recti muscles are a little bit splayed apart and they have a bulge when they lift their heads up, or they lift head up, or they lift their feet up. That is not a hernia. That's just a weakness in the abdominal wall. A hernia is actually a defect in the abdominal wall rather than a weakness. I guess it doesn't really matter much to you. You don't care. It's a bulge, whatever. So the patient doesn't care what you call it. It's a bulge. So they're both bulges. So can a bulge be repaired? Yeah, the bulge can be repaired. So that diversification is very easy to repair. If you have a hernia, which is, as I say, a defect, you need to close that defect. Now, there's different ways you can close the defect. So if you have a hernia on its own in other areas, often you have them in the groin, called an inguinal hernia. And you often need to repair the hernia by putting a mesh on, or putting something over to sort of plug the hole, plug the defect. If you have a hernia and you're having abdominoplasty, often your abdominal wall tissues are lax, so you're often, as I say, you're often repairing that diversification. You're often able to plicate that abdominal wall, and so you can often close a hernia in the process. Usually hernias at the time of abdominoplasty are small, periumbilical, just near the belly button hernias, little holes, little defects, which you can either just stitch, just repair directly, or I did one not that long ago, and she had quite a big defect, which we knew about that big. and I was able to repair it just by using the tissues that are there without using a mesh. If you're getting into things like using mesh repairs, then it probably, well, depending on the plastic surgeon, but it would be often you'd think about getting a general surgeon, an abdominal surgeon involved to maybe give you a hand who's more used to repairing hernias, especially if you're going to start using mesh and things. We can do meshes. Well, it depends on your expertise. I've done a few meshes, but I haven't done a huge amount of meshes, so I'd probably get a general surgeon involved if I was going to have to do a mesh repair of a hernia, so if it's a significant hernia. But for a normal hernia, normal hernia, but not a very big hernia in an abdominoplasty patient, it is a routine part of repairing the abdominoplasty. And we do see people who've been turned down by other places because they've got a hernia, and I'm like, I don't understand. They make a big deal of it, and it's like, it's part of the thing. If you get a defect, just to repair it. So usually pretty simple to repair. Oh, here we go. Khan's got a hernia, and having a tummy tuck will be repaired with mesh. There you go. Well, that goes against what I've just said, isn't it? Well, you can obviously you can, so that's good. So they're good on you, Khan. So yeah, well, if it is big, then you might need to have it repaired with mesh. So that's good. That's a good way of repairing a hernia. So so that's good. That's a live. Oh, I don't want mesh. Hopefully I won't need it. Okay. I've got a hernia and having it the time out. Will it? Oh, sorry. Will it be repaired with mesh? Sorry, I didn't read your question. I didn't read your comment properly. Will it be repaired with mesh? And then I don't want mesh. Okay, Khan. Yeah, I don't think you're my patient. I don't think. I know. I wouldn't forget Khan Olia. That's for sure. So yeah, you better ask your surgeon about that. But if you're having a tummy tuck and having a hernia repair, you probably won't need a mesh. Yeah, probably won't. Sorry, that does. So that goes along with what I've said. Well, we don't know if it goes along or not because we don't know whether you're having mesh or not. So it's my shirt look a bit. I need those collarbones in, don't I? God, you don't often see yourself, It's not seeing yourself. Anyway, so thanks, Khan. Excellent. That's what we need. Bit of interaction relevant to no. Yeah. No. So excellent. Yeah. Thank you, Khan. Thank you. Good to have a bit of input there. We've got a question, two-part question, but I couldn't fit it on the line, so I've put it on 2 lines. How long after chemotherapy or radiation therapy can breast reconstruction be done? And then the next question is related. So again, surgeon dependent. Some surgeons say a year. I say 6 months. So it is a bit surgeon dependent. The reason is you've got to let the tissues recover. So whatever you say, you have to see the patient and see how they're going, because sometimes patients recover very well from chemotherapy and radiotherapy. Sometimes they take a bit longer to recover. So, as a broadly speaking, I normally say 6 months, because if someone's going to have radiotherapy or chemotherapy, I think it's a lot to say to them. You've got to wait a year for your reconstruction. So what I normally do is I say, look, see you at 3 months, see how you're getting on, and then we can think about booking it maybe for 3 months, hence. But it depends on the tissues, how they react. If they've, especially after the radiotherapy, if things are very woody, things are very tight, you might want to leave it longer. So for that reasons, a lot of people are standard a year. So it depends on the surgeon, but it also depends on the patient and how you react. But that's sort of broadly speaking how long you would wait. I'm not your patient. No, you're not. Oh, calm. Well, good luck with that then. They should be fine. Yeah, hopefully you won't need a mesh. But yeah, perhaps check out with your surgeon before you sign the form to be sure you know what you're doing. Not you want to get repaired, whatever, I guess. But where then? This is the second part of that question. Where does the skin and other tissue come from for natural breast reconstruction? Yeah, a lot of places is the answer to that. There's a lot of places it can come from. There's 2 really common places, 2 sort of way up more common than all the others, and those 2 are the back, which is called the lat dorsi flap, which takes a muscle and a skin paddle from the back, and the tummy. The main differences being the back is a slightly smaller operation, but still 4 or 5 hour operation. None of these are small operations, but it's a smaller operation, but it gives a smaller breast. I normally say about a B cup, so then you can augment it either with an implant or with fat grafting. And the tummy is a bigger operation, but it gives a bigger breast. If you have a breast with a droop and things like that, then you're much more likely to be able to recreate it with tissue from the tummy. You take the same tissue you take with a tummy tuck, so you get a tummy tuck at the same time. Not all patients are a candidate for the tummy, because if you've had a tummy tuck before, or if you haven't got enough tissue, to take that amount of tissue that you would take on a tummy tuck, you might not be a candidate for it. But those are the two areas you take the tissue from. There's different ways you can do the tummy flap. You can do a tram flap, which can be pedicle or free. You can do a Dieppe flap, which is always free. I won't get into that. If anyone wants me to get into that, I can get into that, but I'm not sure if it may not be relevant to you. But those are the basic things: the tummy and the back. But there are loads of other places you can take it from. You can take it from the hip. You can take it from the thigh. You can take it from the buttock. There are lots of different places. Thinking about it, I say lots of different places. Those are probably the main ones, actually. Yeah, hip, thigh, and buttock. But there's a couple of places on the buttock you can take it. You can take it from the inner. So I suppose it's still thigh. Yeah. Okay. Well, that's it really. So those are the other places. They're a little bit more esoteric, a little bit more difficult. Probably needs a real specialist for those, because they're quite uncommon operations, and so you need someone who's familiar with them. But the tummy and the back are the two main ones. Good question. Thanking you. Is the lighting all right? I tried to make it moody lighting. Oh, the battery's in PC. Oh, you're kidding me. You are kidding me. Battery's in PC saver mode. Okay. Okay. Is tattoo on the chest suitable for excision? So, this is a patient who has actually sent me a photo of a tattoo, and it's on the chest. And I said I'd mention it here. So I don't really want to show the photo because I'm not sure. Can you get me the power for my computer? It's plugged in next to the lamp, please. So this is a lady who's got a tattoo. Is that being actioned? That's not being actioned. That request, sorry. Yeah. Could you action the request, please, Ella? Could you get the power for my computer, please? It's by the lamp. Yeah, thank you. So it's being actioned now. What she's done is she's pinched it. She's pinched her chest like this. Put 2p on it and things to say, is it suitable for excision? And the answer to that is yeah, because I always say if you can pinch it, then it's suitable for excision. So in those terms, it is suitable for excision, but it's the area that it's in. Thank you. It's the area that it's in that's the problem. It's on the chest here. So whilst it can be excised, this particular patient has had laser treatment, and I've got to say it's faded it pretty well, the laser treatment. And my advice, I would say, is it worth? Because what she's saying is the laser treatment has scarred it, so I've got a scar anyway. But the laser treatment has scarred it to make it just look a bit paler than what it normally looks. I'm just going to plug this in. So it's not really the same as a scar that you get from excision. So it's not really the same. Scar from excision will be a line, and it's not a great place for the scar because it's quite a cosmetically sensitive up here. It's not a great place for the scar. It's quite cosmetically sensitive. So it can be excised, that tattoo. You're pinching it to show that it can be excised, but I would say that the scarring may well be worse than what you've got. And I would think twice about excising it, is my message on that one. So now what we've got here is we've adjusted the microphone. Thank you. Hello, testing. Right, where are we up to? Is tattoo? No. Will I lose any sensation in my nipples or breasts after having a breast augmentation? Steph, got it. I'm on it. Will I lose sensation in my nipples or breasts after having a breast? You might have a change in your sensation of the nipples or the breasts after a breast augmentation. It is usually transient is that better? In terms of it usually comes back to life. it depends a little bit about the incision that's made. So I pretty much always use an inframammary incision, and and that just sort of cuts, that goes underneath the breast, so you're actually cutting into any breast tissue. And so, but you are stretching those nerves, and it's often a problem early on. Sensation of the nipple and the skin can be altered, can be low, can be, you know, less sensitive, can be more sensitive, can feel weird, but it usually comes back to life. It can take a year for it to come back to life, though. It can take a long time for it to come back to life. Other incisions, so there's infraareolar incision, just a U at the bottom of the areola, does cut through some breast tissue. There's more likely there's potential for a problem with the breast, for the nipple sensation with that incision, but we pretty much always use the inframammary incision. So yeah, it can happen early on, but it usually comes back to life, but it can take a while for it to come back to life. Steph, what is your favorite type of surgery stroke treatment to perform? I thought about that, you know. It's difficult. I do a lot of breast implants, but some of them are more difficult than others. And sometimes when you have a difficult asymmetry, I had one the other day, in a way that's quite a rewarding thing to do, because it is a huge difference for the patient. You know, this is a young patient, and she'd been living many years with a significant asymmetry, one totally different volume and shape. So that's rewarding, but it's a very difficult surgery to perform, because you're doing totally different things to both breasts and trying to make them look good, not only in the early stages, but you've got to make them look good over time. You know, I often say that plastic surgeons work in 4 dimensions, you know, because we've got the dimension of time. So that's challenging. That's quite a stressful one, though. So is it favorite? It's favorite because the patient was very happy. Any patient that's happy is a good surgery for me. I do like tummy tucks. I do like doing tummy tucks. I do like liposuction. Liposuction is really great. I love doing liposuction. It's really rewarding because you see the fat coming out. It's great, and tiny incisions. Not many complications. So you know what? I do the surgery I enjoy, because I just don't do any of the other stuff. Don't do the faces. Don't do the Botox. Don't do the fillers. I just do the stuff that I enjoy. So you know, and other people are specialists at that, and let them do that, and that's what they do. You know, I just do the stuff that I enjoy doing. Life's too short, right? But thanks, Steph, for that. What's going on here? Right, okay, next question. Quick, guys, quick. Let's get a question up there. Right, that's good. Will inverted nipples cause me problems in the future if I don't have corrective surgery? No, they won't. The only problem potentially, if you were to breastfeed in the future, it might be difficult to breastfeed with inverted nipples. But if you have them corrected, the best way to correct them is to cut the ducts, and you definitely won't be able to breastfeed then. So that's not a reason to have them corrected. You can have them corrected leaving the ducts intact, but it's really hard to do that, and it often doesn't correct it very well. So from a sort of functional point of view, I wouldn't make that a reason to have them corrected, although sometimes people can have problems with hygiene because they are hard to clean and you get skin and stuff in the inverted nipple, but they're probably not going to cause you any particular problems if you don't have them corrected. So it's actually okay to not have them corrected if you don't particularly want to. Here we go. Trisha Cassandra. Nice. I'm thinking of having a tummy tuck, but I'm apprehensive. It's a result of weight loss. You know what, Trisha? I'll see you over what. Oh God, I'm getting so tangled up in more wires. It's a big deal, a tummy tuck, Trisha, and it's okay to be apprehensive, and it's knowledge is power, Trisha. And I think a lot of people, you know, what I would say to you is, you know, maybe speak to people who've had it done. Make sure your fears are based on facts. You know, people worry about stuff and you think, well, that doesn't happen, you know. But nevertheless, it is a big operation. It doesn't, did I say that right? Operation, it does knock you back. Yes. YouTuber. I'm a YouTuber. That's what they have in YouTubers, aren't they, these mics. So it is a big op, and it is something to consider, and you have to weigh up the pros and cons, and there's no question there are cons. Big long scar, big op, bit of a downtime in terms of you're not back for a while. It does take a while to the final result to become apparent. It's quite swollen, it's expensive. So there's lots of things to consider, Tricia. But what I would say to you, if you are apprehensive, make sure that you're fully informed and make sure that your fears are based on fact, because a lot of people, as I say, think that people are going to be a certain way. We've got a videographer now, full-time videographer, and one of the things I really wanted to do, we've got to get approval from the hospitals, is to maybe do a bit of video before someone has operation, maybe a bit during the operation, but not much, because I think I don't think people do want to see that, but certainly after the operation, maybe in the immediately, the day of the op. I think it would be nice to have a little thing to say, look, how are you doing? How's it going? Just a quick, little bit of a video saying how you're feeling, for people to see what people are like immediately after a tummy tuck or a breast augmentation or a mastopexy. Because I think they think that they're going to be like, ooh, rolling around in agony. But, often they're just like, oh, yeah, it feels a bit uncomfortable, and then day one, day two, just see how they go. That's one of my ideas. But it's okay to be to be apprehensive, but as I say, make sure it's in fact, and talk to people having it done and had it done and stuff like that. That's a good question, Jade. What's a good question? Jade's got a question. Do you recommend having different procedures at different times, or is it okay to do multiple surgeries at once, such as tummy tuck and breast lift with implants? Nice one, Jade. That's a good one. You know what, Jade? I talk to people about pros and cons of stuff, and anytime there are different ways of doing things, there are that means there's no one good way of doing it. So the fact of the matter is, some people have staged procedures, some people have it all in one go. Both are fine, and both have got their pros and cons. It is very common to have a breast procedure and a tummy procedure, like a breast lift with implants and a tummy tuck at the same time is fine, normal, standard. And mummy makeover, they call it, which is a breast and a tummy thing. But it is a big thing, and it does knock you back. Probably the tummy tuck will be the sort of overriding thing that you'll be recovering from, and you'll sort of recover from the breast while you're recovering from the tummy tuck. But it is a big thing to consider. But a lot of people want it done in one, because it's one time off work, one episode of recovery. There's a financial benefit. It's a bit cheaper, not massively, but it's like 20% of the cheaper procedure. That's how they work it out. So it is a bit cheaper to have it done in one go, but I think it does suit a lot of people just to get it all done in one go. And as I say, usually what happens is while the tummy's recovering, your breast is recovering at the same time, so you sort of but it's a lot of wounds and bits and bobs. You can get problems. Oh, that's sore, that's a bit numb. Oh, I've got a bump at the end of my scar, I've got this and that. So it can be quite stressful. It can be a lot to go through. And so a lot of people think, oh my goodness me, I can't face that. Let's just do one at a time and just get one sorted, and then 6 months, a year later, get the other sorted. A perfectly reasonable way of doing it. So I don't particularly recommend people have them done at different times or the same time. I talk to them about what they involve, and to see what they think is right for them in their life at this point in time, to see how they feel they would cope. But I would say that if you need a tummy tuck and a breast lift with implants, say, there's a lot to be said for getting it all done in one go. I can understand that. I can understand how people would want to just get it done, get it out of the way. So yes, thanks, Brenda. That was a good question, Jade. Very good. Can't give you a thumbs up, but I'll tell you what I can do for you. I can do that. How's that? Thank you for that. So, is fat transfer successful? Is it permanent? That's a surprisingly good question. Not a surprisingly good question. That's a bit, but that's a bad thing to say. Surprisingly good question, because you might think, "What is it successful? What are they asking that for?" Of course, he's going to say it's successful. Fat transfer is a funny thing. I think it is a very good technique. It's very popular at the moment, and a lot is spoken about it at meetings, and it is a good, brilliant technique, and it has its useful uses. But when you say is it successful, it's like any surgery, it's about patient selection and it's about patient expectation, because you have to be aware of what it can achieve. And the problem with fat transfer is it is always subtle. The results are always subtle. In my hands, I'm just talking about everyone, you know, I think you have to see what your surgeon can do. But in my experience, it's subtle, the results. And you have to look at the before and after photos quite closely and say, look at that, it's a bit fuller there, and that's giving you a bit better contour there. It's not, particularly if you're using it in terms of, like, for instance, breast augmentation. You know, when you put in 250cc implants into a patient, they come back, fantastic, I've got 250cc implants in and I feel great. And I knew that I was going to get 250cc implants because I had a sizer and I looked at the shapes and all this sort of stuff. I knew what I was going to get. With fat graft, things like, well, we'll see how much we can put in, you know, 50, 100 cc's. It's often subtle. And you might say, I want subtle. I don't want any of the problems that are associated with implants. And I like the fact that it's natural, blah, 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 and all these things. There's a lot of good things about it. It's natural, it's permanent. It's your own body. It'll affect as you put on or lose weight, it gets bigger and smaller. So there's a lot of good things about fat transfer, but it is subtle. So that's where you get into, is it successful? As long as the patient is expecting that, it is very successful, and it actually has quite a low complication rate. There are complications that can occur, oil cysts, fat necrosis, infection, but they are not very common. But mainly because I think we use small volumes. I think if you use small volumes, you might get into more realms of complications, but maybe patients are happier because you could put in big volumes. We tend to use small volumes, therefore don't get many complications, but also subtle results, balance. So is it permanent? Yes, it is. Now, having said that, it's always swollen to start off with, then it settles. So people think that's it's resorbing and things like that. It's just the swelling settling. So it does change in the first few months, but once, 6-12 months, once it's there, it's permanent, and it's your fat, and it takes like a graft. It's just like a skin graft. It's your, it's skin, and it takes, and it is your fat, and it responds to fat in the same way. Responds to fat, responds to weight changes in the same way as your weight does change, respond. Yeah, nice question, that one. Nice one. What's going on now is we've got a question here which says, what is done in arm lift surgery? Is liposuction performed in this surgery? Good question. This question really made me think, because I try and think about content for the website, information we need to be giving to people, because obviously I know what an arm reduction is, but people out there probably think, what's an arm reduction? I thought that's a good question, that, because an arm reduction sounds like, how do you do an arm? Would you reduce an arm? What's that all about? So it did make me think that. I thought that's a good question. That maybe we need to get down into. It's hard when you're sort of a doctor and you're trying to write content for the website and give people information, because you're sort of, you've got to get on to the questions they want to ask. That's why this is good, this Q&A thing, because it's interesting for me to see the questions people ask, because I think that's a question. It's a really good question, and it's not the sort of thing I would naturally think of sort of saying, what's an arm lift, but actually good question. So I'll answer it, shall I? So an arm lift can involve liposuction. An arm lift is a body contouring procedure, and when you strip everything back and strip everything down, it gets pretty simple. A lot of body contouring, and body contouring is arm lifts, mastopexies, tummy tucks, thigh lifts, face lifts even. It usually involves tightening the skin, usually, and it's usually because of age. We lose elasticity in our skin over age. Things sag. Things like pregnancy can affect the tummy, weight loss, putting on weight, losing weight, your body shape changes, your skin stretches, and you have excess skin, and the surgery usually revolves around tightening the skin and improving the contour. Now, liposuction is good for removing the fat, and liposuction is good in certain areas. Having said earlier that I love doing liposuction, I do love doing liposuction. I don't do it very often, to be honest with you. And the reason I don't do it very often is because it's got an indication for certain areas. There's certain areas where it works really well. Areas like the outer thigh, I just went on my hip, then the outer thigh, the hips, the male chest. There's certain areas where when you do it, the skin recoils quite well. And so liposuction has really good results. The problem comes when the skin doesn't recoil, because liposuction doesn't do anything to the skin. I've spoken before about assisted forms of liposuction and different types of liposuction, things which do report to cause some degree of skin retraction. I don't really do them. How much skin retraction they cause, I'm not sure, because I don't do them. And I think it's often quite subtle. But broadly speaking, liposuction removes the fat and doesn't do anything to the skin. And what you need is the skin tightened often. So often the case in an arm reduction, people often want liposuction. But the problem with liposuction is that the skin is it's an arm reduction is for what they call bat wings or bingo wings, and it's fullness here. This bit here, fullness in the arm, is the bit from your elbow to your shoulder. The bit from your elbow to your wrist is your forearm. So this is your arm, this bit here. And it's reducing the circumference of the arm, and usually, but when you put your arms out, there's too much skin and you get these bat wing or bingo wings or whatever you want to call it. And so an arm reduction is addressing that. Now liposuction will take out the fat, but it doesn't make the skin recoil, and the skin in that area is often quite thin. The outer arm is thicker, a bit like the thigh. The outer thigh is thicker, the inner thigh is not so thick. And so in my experience, liposuction has a limited effect. If you have a specific bulge or a problem, then liposuction might help, but really it's a skin problem. And so what I do for an arm reduction is I cut that skin out. And anytime you cut the skin out, you give a scar. Now, it's the same for a tummy tuck, same for a mastopexy, but you try and hide the scar as much as you can. Now, in mastopexy, you can hide it in a bra. In a tummy tuck, you can hide it in the underwear. It's a bit more difficult to hide it with an arm reduction, because often the fullness goes down to the elbow. So you have to make the scar down to the elbow. I don't pass the elbow, so you go just a little bit above the elbow. Now, you try and put the scar in the neutral position of the arm. So when you hold the arm out, you can't see it from the fat or the front or the back, but when you hold your arm up, you can see it. So an arm reduction is usually involved, well, in my hands, it usually involves cutting skin out. And I don't usually do liposuction. Some people do liposuction as well as, if you do liposuction as well as cutting skin out, you have to cut less tissue out, because you are liposuctioning it first to empty it. And I think that's a good technique. The problem is, anytime you use liposuction, it's more expensive because you have to get the liposuction equipment out. So I don't do liposuction at the time of a arm reduction routinely, but it can be done at the time of arm reduction to sort of facilitate the skin excision. But the main part of it is the skin excision. So doing liposuction alone is usually not great for a fullness of the arm, unless there's a bulge. We've gone nicely on to Brenda's back in here. Brenda, you've been a big contributor tonight. Big yourself up for that one. Thank you. Can you have lipo on the forearm? You can, Brenda. You can have lipo anywhere where there's fat, and there's fat everywhere. It's really good for localized areas of fat. There's not normally to sort of contour a forearm. So if you've got a bulge of fat, if you've got a lipoma or a bulge of fat on your forearm, I think that would be good. If it's the whole forearm that's too full, I would say weight loss is better than for that. I wouldn't do liposuction to sort of contour the whole forearm. So you can have it on your forearm, yes, but you've got to think why and what sort of area are you having it done for. So yeah, I've got to get back in here. So yeah, that is what an arm lift is. Who is a good candidate for gynecomastia surgery? Yeah, I'll think about this one. Okay, someone who's not overweight, number one. So there's for two reasons. First of all, when you're overweight, your risk of complications is higher. But secondly, if you were to lose weight, your gynecomastia might get better. Now, I'm not saying it will get better, but it might get better. So when you have gynecomastia, the first thing is to see if there's a cause for the gynecomastia and remove the cause. If you don't remove the cause, it's pointless doing surgery. So obesity is a cause of gynecomastia. So if you are overweight, you should lose weight first. If you are going through puberty, you should go through puberty first, because puberty is a cause of gynecomastia, same as senility, so in older people. But certainly if you're going through puberty, it's better to wait. Well, not better, you must wait, because it might get better naturally. if you're on certain drugs, then that can cause gynecomastia. You should stop that. The most common of which is the anabolic steroids for bodybuilders and what have you. If you're not stopping those drugs, then you're not a good candidate for gynecomastia correction because it will just come back. So, a good candidate for gynecomastia is someone who is a non-smoker, who has a problem that can be corrected with surgery with realistic expectations, who hasn't got any predisposing causes. I feel like I'm in an exam here. I don't think I answered that very well, but anyway, who hasn't got any pre-existing conditions, and those are the common ones. There's also rarer things, but those are the common causes that you need to have thought about before having gynecomastia correction. Now, this is a long question. I'm going to get my dual screen up because I had to make this question shorter. This is I have my left breast implant encapsulated and I want to remove the capsule and change my implants. I want to know how long should I wait before I can hold my 2-year-old daughter. She always asks to be in my arms and I'm scared to do it quick and create the same problem. Okay, so the answer to that question is, so you've had this surgery done. Removing capsules and changing implants is actually quite a big op. As you know, in terms of breast surgery, it's right up there. It's a big op, and so you've got to take it easy. So again, I don't think you're my patient. So I'd follow the advice of your surgeon. For me, I would say, look, wear a supportive bra. That's good because the problem you're going to get is swelling. That's the problem, because it is quite a sort of traumatic thing to do to the breast to remove that capsule and change your implants. So swelling is going to be the problem. So it's good to wear the bra day and night, in my view, and it's good to take things easy, so you don't want to put too much power through your upper body. Now, holding your 2-year-old daughter, the problem is picking her up, isn't it? Because she's going to be quite big at 2. So I would just sit down and maybe put her on your lap. Do it gently. It's hard when you've got a small child. I always say to people, no heavy lifting for 4 to 6 weeks, but when you've got small children, you can't really not hold your child if you've got a 2-year-old, so just maybe just think about it, and rather than picking her up from a standing position, just sit down and sit her on your lap. And basically, if it hurts, back off. If it hurts and if it starts to swell, back off. But it's okay to hold your child, and hold your daughter, even if it's a week or 2. I don't know how far after surgery you are, but a week or 2 weeks after surgery, once your wounds have healed, your dressings are off. If you're feeling okay, I mean, if it's really tender and really sore and swollen, then don't. But if it's feeling okay, then yeah, I would have thought you could, and just see how you feel. And if it's uncomfortable, then don't do it. And you're saying, I'm scared to do it quick and create the same problem. You're unlikely to create the same problem. Hematoma is a cause of question. Hematoma is a cause of capsule contracture, but you're not going to cause hematoma by just holding your daughter. Really, it's just going to make it swell a little bit. So as long as you're sensible and you take it easy, I think after a couple of weeks, I would say you can hold your daughter, but just go easy. Don't go throwing around and putting her on your shoulders, sort of thing. But you probably won't feel like it. A lot of it is how you feel. Your body will tell you, and if you feel fine, then it's usually okay. Body's pretty good, telling you. Seromas, how to distinguish them, how to know which ones will self-absorb and which need to be aspirated, how to prevent seromas. Oh God, sorry. Hold on. There. So, how to distinguish seromas, how to know which ones will self-absorb and which need to be aspirated, how to prevent. Okay, this is a good one. So seromas, I'm going to guess this is a tummy tuck. The areas that you commonly get seromas are your tummy and your back when you do that lat dorsi flap for the breast reconstruction. You can get seroma anywhere, to be honest with you. After any surgery, you create a space and that space can fill with wound fluid. So how to distinguish them? I guess the main difference, the main thing you're distinguishing a seroma from is, well, the two things I guess are hematoma and swelling. So to distinguish a hematoma from a seroma comes quite early on after surgery. The first day or so after surgery, you get a hematoma. It looks the same. Let's call it a tummy for now. So your tummy swells up. hematomas are often expanding. So hematomas are often something bleeding. It's getting bigger and bigger and gets really uncomfortable, really tense and really uncomfortable. The seroma usually doesn't get that tense. The seroma just gets full and sort of stops once it gets full. So if it's getting fuller and fuller, and certainly if it's the first sort of day or so after surgery, then hematoma is more likely than seroma. But if it's a week after surgery or more, then a seroma is more likely. The other thing that you have to distinguish it from is just swelling, because you always get swelling. So swelling is just edema of the tissues, swelling around the tissues. Seroma is actually fluid sort of sloshing about. Oh, here we go. Brenda got one after a thigh lift. Yeah. So anytime you make a space, you can get a seroma. So seroma is actually fluid sloshing about in that space, whereas swelling is edema of the tissues, and just like when you bang your arm, it all swells up. So the way you differentiate it is you will often know, because when you move you can feel it sloshing about, you can feel fluid about sloshing about. One thing that we do is we do something called, the mic's working, we do something called ballotting it. And ballotting it means putting your hand on one part of your tummy, and then tapping the other part and feeling a thrill on the other hand. That's ballotting it. That's seeing if there's that's seeing if there's free fluid there. So you can ballot it to see if the fluid, you can hit the fluid on one side and have it feel the thrill on your other hand. That suggests there might be free fluid there, but you as a patient will often think, actually, it feels like there's a hot water bottle in there. So I guess those are the main things you need to distinguish it from. So if there is, the other thing is you can put a needle in, and if you get fluid out, then it's a seroma. If you get blood out, it's a hematoma. And if it's you don't get anything out, then it might be in the wrong place, or you might have a swelling. But so that's sort of I guess seroma and swelling are the main. Hematoma and swelling are the main things you want to differentiate it from. How to know which ones will self-absorb and which need to be aspirated? They will all self-absorb, really. And really, you aspirate them when they are a problem. So when they're uncomfortable. So if you have a small one that's not really causing you much bother, then it's good to wear some kind of compression, not too tight, but maybe a bind or something. A bit more difficult with a thigh lift. You can get compression garments for the thigh. They're a little bit more difficult to wear than the abdominal binders. But if you can get compression on it, lat dorsi, you can't really get compression on it on the back. So you so compression is good, but if it's a small one and it's not really bothering you, then you can just watch it. They usually get better. So my criteria for aspirating it is when the patient is affected by it, and if it's a really big one, it's going to resolve and it's really swollen and tense, I would drain it. It's usually relatively simple to drain it. It's done in the outpatients. That's the big difference between a hematoma and a seroma. See, a hematoma is blood, so blood won't come out with a needle because it clots. So if you get a hematoma, you have to go back to theatre and have it washed out. Whereas a seroma is much more easy to deal with. Something you can deal with in the clinic. Just put a needle in. Often the sensation's a bit funny of the skin anyway, so hopefully it won't hurt too much. And you can aspirate it in the clinic. And the problem is there's still a space there. So it usually recurs, but it recurs less. So you might need to have the aspiration repeated, but I would wait until it's uncomfortable again, because you don't want to be aspirating it too often, because there is a small risk of introducing infection and things like that when you're putting the needle in. So you don't want to sort of aspirate it for no reason. But certainly if it comes back and is troublesome again, you can aspirate it again. And hopefully after a few times, it's maybe not so big, and then you can just leave it and say, let's see how it goes. And hopefully it'll start to resorb on its own. You sort of helped it on its way to resorb by aspirating it. How to prevent seromas? You try not to leave too much of a dead space. We call it dead space. So you can do things like quilting sutures. Drains will close down the dead space. Sometimes for some operations, people use glue, like lat dorsi on the back and tummy tucks. People spraying glue to try and all these things are trying to close that dead space to prevent there being seromas. So there's quite a few things we do as surgeons to reduce the risk of the dead space and the seroma. But all the things we do have pros and cons, which is why people do different things. And you can certainly talk to your surgeon about what can be done to prevent the seroma, but you've got to balance, you know, that against causing a different problem. But yeah, those are the sort of things we can do to prevent seromas. That's my last question, and I'm looking on my email to see if Smidge has emailed me. So I'm not seeing an email, Smidge. So, because you contacted me on Facebook earlier and said that you wanted me to have a look at, I think it was your friend's result for something of some surgery. So, if you do email me, I will answer you by email. I can certainly talk about it at this in this Facebook Live next week, Tuesday, because we're back from holiday now, so no longer on holiday because last week was half term. So it's good to be back. I'll be back again next week, 7 o'clock. Very much looking forward to it as ever. If you've got any questions, please email me the questions. Brenda, you've been a star. Don't you thank me. I want to thank you. Thank you for your input. So if you have any questions, then is that please comment and share? That's probably not the right thing to put. What should I put? Live Q&A? No. Maybe I should do a new one saying. I haven't really got a thing that I can say. Anyway, I'll say it in words rather than putting it there. Yeah, just email me or give us thanks, Zoe. Give us a you know, Facebook message, or just come on and ask a question. You know, I'm happy for that to happen. Great, fantastic to have so many questions tonight. It was a 2-weeker, so we've got 1 week till next week. So if you think of any questions, please feel free to. Terry Pierce has been a dark horse, just coming at the end there. Hi, Terry, good to see you. Look at this, all these words of encouragement. Informative education, what was it? Oh, thank you. So yeah, so please do get in touch if you have any questions. I would love very much to receive them. That's all we want to see. Multiple comments. Thank you, Jade. And I'm going to check out, and I tell you what, it's gone very quiet out there. Goodness knows what's happening. I am supposed to be in charge, and I'm an unfit parent because I've been doing this. So it's fine. She's 13. She's 13. It's not that bad. Anyway, I'm going to go and check them because it's a bit too quiet out there. See you next week, 7 o'clock. It should be all right for 7 o'clock. I can't remember what I've got on next week, but it should be all right next week at 7, I hope. And I'm looking forward to it already. Have a great week, everyone. Bye.